Okay, so this is the last little mini lecture in this series, and then you can take a sigh of relief. You are done. There's a lot of stuff on the newborn period, and when we talk about autism and things like that, that make these videos kind of lengthy. There's a lot of stuff, but this is just an introduction to how polygenic complex disorders can work. We're using two disease processes: diabetes mellitus type 1 and asthma, just to show you how that works. It's not meant to be an exhaustive conversation about diabetes or about asthma. Those are topics for other courses: pediatrics, community health, med surg. This is just how genes and the environment work together. So, complex disorders have multiple gene involvement. Usually, it's a function in the body that is so critical that it takes more than one gene to regulate its function. Requires both genetic and environmental input for expression. You have a susceptibility, and then there's an environmental trigger. So, our first sort of exemplar of this is going to be type 1 diabetes mellitus. This is what was formerly called um, juvenile diabetes. We are seeing it sometimes in older people. But what it is you have a genetic susceptibility, um, and then there's an autoimmune response to a virus, and it attacks the beta cells, those insulin producing beta cells in the pancreas. And now they can't make insulin. And it's characterized by chronic hyperglycemia that only responds to insulin therapy. No other medication will help. Predisposition is inherited. So if you don't have the gene to develop type 1 diabetes, you won't get the diabetes. If you have the gene, but you're not exposed to the environmental trigger, you won't get it. But the combination of those two is like a perfect storm. So, and there's probably more than one gene implicated. Expression of the autoimmune disorder requires, as I said, that environmental stimulus. Autoimmune disorders can run in families. They can actually run in individuals. If you have one autoimmune disorder, it is more likely that you will have others. They don't follow Mendelian inheritance. It's not a single gene. It's sort of like instead of a single note on a piano, we now have a little tune. Type 1 diabetes usually develops in childhood, can develop later. Genetic contribution, susceptibility. So there are certain genes that code for an inflammatory response through the human leukocyte antigen. They code for specific tissues. So it's part of your immune system. Most closely associated tissue types are HLA. You don't have to memorize this. DR and DQ types. These tissue types double the risk. It's still low. Okay, so you need to have a couple of different genes that are associated with autoimmune responses that attack the pancreas. Then, environmental contributions. Type 1 diabetes is not caused by obesity, is not caused by sedentary lifestyle, it's not caused by eating too many carbs. Type 1 diabetes is caused by an interaction between those genes that trigger a more aggressive immune response and a viral infection. Mumps, rubella, and Coxsackie virus have all been implicated in type 1 diabetes. Because the HLA gene that's defective targets the pancreas, it will destroy the beta cells. We know the signs and symptoms of diabetes mellitus. This is not new information, but typically when a child, how do we diagnose it? Parent will bring the kid in. Sometimes they've lost weight. They're excessively thirsty. They pee all the time. They're lethargic, and they've lost weight. I have heard of cases that were not diagnosed until the person went into DKA. Parent knew something was wrong, but they didn't know what it was. They thought it was the flu. And then some crisis triggered diabetic ketoacidosis. Long-term complications, we know what they are. Kidney disease, neuropathy, both peripheral and visceral. That's like your gastroparesis. Retinopathy, we have all the cardiac conditions, poor wound healing, increased risk for infection, amputations, lower extremity, many, many complications of diabetes mellitus. In type 1, the only therapy that really works is insulin therapy. And we have to watch the glucose so that we can adjust insulin therapy. Children are taught at a young age to count carbs and adjust a dose of insulin. They are not taught to restrict their intake of carbs, just to count them. Because what they found in the research was that when you tell kids to stop eating what other kids are eating, they rebel and they do not manage their disease well. So now it's fine, eat whatever you want, but you need to know the carb count in that meal or snack, and you need to adjust your pump or inject some insulin. There are many specialists that are involved in treating type 1 diabetes. Most people get referred to a children's hospital that can sort of do that one-stop shopping, so that you see an endocrinologist to manage your insulin, a cardiologist to look at your cardiac risk, ophthalmologist to look at your eyes. You might see a nephrologist to keep assessing your kidneys, podiatry to look at your feet, nutrition, make sure that the child is getting enough nutrients to grow and they're not losing too much weight, and a diabetes educator. Children's hospitals, as I said, are good places to get support, and the American Diabetes Association is another place. All right, last one is asthma. Okay, again, not an exhaustive discussion of asthma because you have that somewhere else, but it is a chronic inflammatory disease of the airways. You guys kind of know what asthma looks like. You get intermittent episodes. They are called asthma attacks. And what it is, you have constriction of the smooth muscles surrounding the smaller airways. And then you get swelling and you get mucus plugging and you'll hear wheezing in the lungs because the airways are now constricted. The patient will complain of having a tight chest. It is polygenic. 50 to 100 genomic variations are associated with asthma development. Some are specific to different racial and ethnic groups. We see some disparities, but be careful of that. It's not all because of genomic factors. Some of that is due to communities that are less healthy than others. So we need to work on that to even out the score, make sure that people have equal access to good health. Most of the genes that are involved code for proteins that are involved in inflammatory reactions and immune responses, and you get that hyperactive, but they're tissue specific and they go to the lungs. There are genetic pathways for airway responsiveness and production of inflammatory mediators. It's all very scientific. You don't need to memorize any of that. Just know that there are many genes that are involved in the pathophysiology of asthma, but that they usually have an environmental contribution. So exposure to inhalation irritants. And I don't know why it's not on here, but it is. I'll talk about it in a second. So cigarette smoke or wood smoke, children who rely on wood burning fireplaces for heat can take in some of those irritants, any kind of chemical exposure, cold, dry air, fine airborne particles like dust or pet dander, microorganisms. That's what I was looking for. So viruses like cold viruses, a lot of times will trigger exacerbations of asthma. And people have exercise-induced asthma where the increased demand for oxygen triggers sort of an inflammatory response. Ingestion of aspirin or other NSAIDs will sometimes trigger asthma as well. Signs and symptoms, you guys should know these. I'm really not going to talk about them extensively, but difficulty breathing, chest tightness, coughing, wheezing, increased mucus, use of accessory muscles. How do we treat it? From a genetic standpoint, if you know that one sibling has it, you know that the other siblings are likely to be vulnerable to it, so you would have mom monitor them. You should have an asthma action plan, and this could include the use of a peak flow meter, a multi-dose inhaler, like albuterol, which is a bronchodilator, as needed, and then maybe an inhaled steroid like Qvar, which would decrease the likelihood of inflammation. Make sure that you are reducing the exposure to allergens and environmental triggers. If there are pets, you might want to get an air purifier, brush the pet outdoors. Steroids, you might have prednisone on hand. We talked about inhaled steroids, but in the event of an exacerbation, pediatricians will usually give parents a prescription for prednisone that they can fill and have on hand. And that way they don't have to worry about getting a prescription in the middle of the night. and then going out to a pharmacy and filling it. They have it in the house. They just use it when they need it. Bronchodilators, either with neb treatments or multiple dose, meter dose inhalers. Support. Parents can go to American Lung Association, Allergy and Asthma Network, or community health agencies for support. Usually their pediatric provider is good for that. And we are done with childhood disorders. You guys are rock stars. I will see you soon.